Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 383 of our pharmacotherapy series, which majors in pain and its management. The first question in this case reads: SGR is a 38-year-old woman who presents with chronic widespread muscle pain from her neck down past her buttocks. She also has headaches when her pain is severe. She has had this pain for several years and notes that her pain developed after a car accident in which she sustained a whiplash injury. She describes difficulty sleeping, poor concentration, and fatigue. Her pain rating is 8 out of 10 on most days. She works part-time doing some home transcription. She has not identified anything that helps her pain, and physical activity makes the pain worse, so she does not exercise. Her pain is also worse when she is stressed. She was previously told that she has fibromyalgia, and while others have told her that it's all in her head. Her past medical history includes depression and irritable bowel syndrome. She has tried ibuprofen, cyclobenzaprine, carisoprodol, and acetaminophen in the past without relief. She is currently taking tramadol 50 mg by mouth 4 times daily, which provides about 20% pain relief. She is also taking sertraline for depression. SGR is married and has 3 children. She smokes 1 pack of cigarettes daily but denies drinking alcohol or using illicit drugs. She reports that her mother and sister have fibromyalgia and depression. She reports diffuse tenderness to palpation along her paraspinal muscles bilaterally, as well as her bilateral trapezius and levator scapulae muscles and her hips bilaterally. Several tender points are elicited. Her only remarkable laboratory result is vitamin D, 24 nanograms per milliliter. The normal range is above 30 nanograms per milliliter. So my question to you reads: what part of SGR's presentation supports the presence of a functional pain syndrome? SGR likely has fibromyalgia, given her widespread pain that has been present for more than 3 months and was precipitated by a traumatic event, that is a car accident. She reports sleeping poorly, fatigue, and the comorbidities of depression and irritable bowel syndrome. On physical examination, she exhibits widespread musculoskeletal tenderness including, but not limited to, several of the identified fibromyalgia tender points, bilaterally, both above and below the waist. Her vitamin D level represents a mild deficiency. My next question to you reads: what pharmacologic and non-pharmacologic therapies could be recommended for SGR? There have been several evidence-based guidelines published for the treatment of fibromyalgia. These guidelines recommended a multidisciplinary approach with pharmacologic and non-pharmacologic therapy. Because evidence indicates a CNS neurotransmitter imbalance, the most effective pharmacologic approaches have targeted these imbalances. Antidepressants have been shown to reduce pain and improve function by increasing levels of serotonin and norepinephrine in the CNS. Historically, the tricyclics, most commonly amitriptyline, have been shown to moderately improve pain, sleep, and to a smaller extent on fatigue and health-related quality of life, abbreviated as HRQOL. Selective serotonin reuptake inhibitors have also shown some improvement in pain, depression, and health-related quality of life, but the effect sizes were quite small. Duloxetine and milnacipran are both serotonin and norepinephrine reuptake inhibitors that are FDA approved for fibromyalgia. Milnacipran appears to have more norepinephrine activity than duloxetine. This difference does not appear to confer a therapeutic difference. Both of these agents improve average pain scores, FIQ scores, physical functioning, and overall sense of well-being. Gabapentinoids have been shown to reduce the activity of excitatory neurotransmitters, particularly glutamate. Pregabalin is an anticonvulsant that was approved by the FDA in 2007 for treating fibromyalgia. It targets the increased levels of glutamate in the CNS by binding to the alpha-2 delta subunit of voltage-gated calcium channels, preventing release of glutamate from presynaptic terminals. This agent has been shown to improve average pain scores and patient perception of improvement, but failed to show improvement in FIQ scores. A long-term open-label study found that patients who did well in the short term maintained an improvement in pain for up to 6 months compared with placebo. Gabapentin, a similar compound, has not been formally approved for fibromyalgia but has support for its use. Some insurance companies require a trial with gabapentin before allowing use of pregabalin because of its lower cost. Hauser and colleagues compared duloxetine, milnacipran, and pregabalin in fibromyalgia and found that duloxetine and pregabalin were better than milnacipran in improving pain and sleep. Duloxetine was better for symptoms of depression, and pregabalin and milnacipran were better for fatigue. Headache and nausea were more common with duloxetine and milnacipran, and diarrhea was more common with duloxetine. Other drug therapies that have shown some benefit in treating fibromyalgia and its comorbidities include pramipexole, a dopamine agonist, which is beneficial in treating restless legs symptoms, as well as pain and fatigue. Non-steroidal anti-inflammatory drugs, acetaminophen, and opioids are not recommended for treating fibromyalgia pain. In fact, Goldenberg and colleagues conducted a literature review and found no evidence from clinical trials that opioids are effective for the treatment of fibromyalgia. The studies reviewed found that patients with fibromyalgia receiving opioids had poorer outcomes than those receiving non-opioids. More recently, data have been published noting the effectiveness of low-dose naltrexone, an opioid mu receptor agonist, in pain reduction, as well as improvement in general satisfaction with life and mood. An appropriate first step for SGR is to develop a multidisciplinary approach, including physical rehabilitation, cognitive behavioral therapy, and pharmacologic therapy adjustments. She is currently taking an antidepressant, i.e. sertraline, which may be helpful for her depression but is likely not very helpful for her fibromyalgia. It may be possible to switch her to a serotonin and norepinephrine reuptake inhibitor such as duloxetine or milnacipran in consultation with her mental health care provider. She is currently taking tramadol with some relief. She has not maximized her dose. Maximum daily dose is 400 milligrams. However, she is also taking a selective serotonin reuptake inhibitor, which may place her at a higher risk of serotonin syndrome. The risks and benefits of combining antidepressants with tramadol must be considered on a patient-by-patient basis. Because she is having trouble sleeping, she could be offered a trial of amitriptyline or pregabalin, both of which have sedating side effects. Pregabalin is a recommended agent and has a different mechanism of action than the medications that she has previously tried. If cost of therapy is a concern, then gabapentin could be tried instead. A vitamin D supplement should also be considered to correct her slightly low vitamin D levels. There is not strong evidence supporting vitamin D supplementation, but there is little harm in correcting her slight deficiency. Bernardi and colleagues conducted a systematic review of cognitive behavioral therapy for fibromyalgia and found that this therapy improves coping with pain and reduces depressed mood and healthcare-seeking behavior. Hauser and colleagues evaluated different regimens of aerobic activity with a meta-analysis and found that land and water-based aerobic exercise, at a slight to moderate intensity, 2 to 3 times a week for at least 4 weeks, resulted in improvement of depressed mood and increased health-related quality of life scores and physical fitness. This was maintained if the patient continued exercise at home. Aquatic training is beneficial for improving wellness, symptoms, and fitness in adults with fibromyalgia. Luciano and colleagues found that cognitive behavioral therapy is more cost-effective than routine FDA-approved medications for adult fibromyalgia patients. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 384.